Good morning. My name is Nim Lalvani, professionally known as Nim Lalvani. I'm the Executive Director of the American Migraine Foundation, and my conflict of interest has no updates for today. Okay. So I would first like to start off that I am a person impacted by migraine. The American Migraine Foundation, AMF, is the patient-focused organization founded by the experts of the American Headache Society, AHS. I am honored to be here today representing both the patient perspective and the clinical perspective of the American Headache Society. Today I would like to emphasize the following: the patient population. ICER's evidence report broadly addresses the unmet need of the patient population that would benefit from the new acute treatments. However, that focus is lost as the historical triptan data is analyzed. Both AHS and AMF believe that there should be stronger acknowledgement and consideration that although the currently available acute medications are effective for some patients, they are ineffective, poorly tolerated, and/or contraindicated in a great majority of other patients. In addition, triptans remain contraindicated in patients with established cardiovascular and cerebrovascular disease, CV, and any suggestions that decades of use has any way changed this contraindication or relaxed patient or clinicians' concerns of the potential for serious adverse CV events is misleading and not in the best interest of patients. Further, triptan medications and NSAIDs are not recommended for those with a history of cardiovascular disease. Additionally, over 2 million people in the U.S. have migraine and a history of greater than or equal to one cardiovascular event or disease that may limit their use of triptans. The unmet need in this vulnerable population results in pain, disability, and high individual, family, societal, and economic burden. This population of patients may remain on disability and having to rely on medications such as opioids, butalbital-containing and caffeine-containing medication. Opioids, butalbital, and caffeine-containing medication contribute to medication overuse headaches, MOH, suboptimal acute treatment of migraine, and development of disease progression with functional and structural brain alterations. Further, with the U.S. being in an opioid epidemic, we must reduce the use of opioid medications to save lives. According to a report released by the NIDA, the National Institute on Drug Abuse, 130 people will die today and every day from opioid overdose. Additionally, according to a 2019 report in the American Journal of Medicine, 1 out of every 7, that's 14%, of opioid prescriptions are written for headache. We must do better. New effective acute treatment options are opioid-sparing medications. Comparing to the new acute treatments for migraine, the triptans should not be viewed as a replacement for triptans, but instead as new therapies that are filling a gap of unmet need for a vulnerable patient population without an effective and safe treatment option for migraine attacks. Ethically, we cannot leave these vulnerable patients in pain, disability, and an unfortunate path to disease progression to chronic migraine, medication overuse headache, and possible opioid dependence and its complications. On behalf of the American Headache Society, the American Migraine Foundation, and the patient community connected to AMF, I would like to thank ICER for carefully taking the time to review these new therapies. As someone impacted by migraine, I know how important options are for patients who have for so long been debilitated. Thank you.